I think we actually have like 10. So that's better.
It's kind of the same thing, right? That is hilarious.
I start out, me and my kid, like, let's go to the point.
Stop here first.
But I really wanted to understand out what's happened.
Good. Curious, absolutely, yeah.
Yeah.
Now that there's so few immigrants, but
Sure, still in need.
So I don't see it.
Yep.
Very underserved.
Maybe we can
Yeah,
start.
So we could still do nurse stuff.
yeah,
I think so.
You
Yeah.
have-
that's right. So that.
There's no way I'm remembering his password.
Give us a plug this time, you know, like, we never
Yeah.
did the plug last time.
We did, yeah.
Plug.
So, let's see.
You got some power.
Oh, but a lot of times I don't. Oh. A million times I can't get on the internet or can't get.
I mean,
on
it
the
is, but-
in here.
Yeah.
How much?
So that's exactly. what I'm saying.
Hello, everybody. We're starting the meeting. Okay, I want to welcome commissioners and members of the public.
Hey, everybody, we're starting. It's time. Sorry. Go ahead.
I'll do it louder.
Yeah, you know it.
This time I did it very loud and then it was too
Oh,
loud.
that's right. That's
Yeah.
right. I remember.
I would love to see that.
Yeah.
Next time.
Okay,
Okay, this meeting is a hybrid commission meeting. There are several commissioners in room 100 and the rest of the commissioners are participating via Zoom and we can't see everybody up there. Given that this is a hybrid meeting, additional ground rules will still apply. I will begin the meeting with a roll call of commissioners. During the meeting, I ask the commissioners and presenters to identify themselves before speaking. That way, commissioners and members of the public will know who is talking and have the same knowledge of who is in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the acting chair. Due to the possibility of background noise, I ask the commissioners and presenters mute their electronic devices when they are not speaking. I would also like to ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. The commission posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice on how to register for and dial into the meeting by posting that information on the homepage of the commission's website and our various social media channels. So I'll now call the roll. Commissioners, Agbapi Aka, I apologize. Are you here? Commissioner Bandari? Commissioner Blake?
Here.
Commissioner Cheatham?
Here.
Commissioner Douglas?
here,
Commissioner Desarasa? Commissioner Foreman? Commissioner Galroot? Here. Commissioner Gilmore? Commissioner Jensen?
Here.
Commissioner Spinner?
Here.
Commissioner Stroughton Duncan?
Present.
And Commissioner Wang?
Here. It's a lovely angle of the room, by the way.
Okay, we have one item on our consent agenda. Approval of the public closed session minutes from the September 18th, 2025 Commission public meeting. Does any commissioner wish to remove any item from the consent agenda? Hearing none, is there any objection to adopting this
Oh,
item
okay.
on the consent agenda? Okay, hearing no objection, the consent agenda is adopted. We're going to skip a couple of things, move a couple of things on the agenda to later, and we will go to agenda item number 4. Item number 4 is action. Residents at Vantage Point in Howard County, the need for nursing home beds. Columbia Vantage House Corporation or residents at Vantage Point is an existing continuing care retirement community or CCRC, which seeks a certificate of need to change its beds capacity by converting 13 of its 44 nursing home beds to public use beds. Program Manager Eric Baker will present the staff report. So Eric, let's proceed.
Thank you, Acting Chair Boyle, and good afternoon, Commissioners. The request before the Commission today is for a certificate of need for Columbia Vantage House Corporation, referenced as Vantage Point or RVP, to change its bed capacity by converting 13 beds of its existing 44-bed nursing home in Columbia, Howard County to public use. Next slide, please. Vantage Point is a nonprofit organization managed by a board of directors with the organization Life Care Services providing operational support services. Vantage Point, a continuing care retirement community or CCRC, is a senior living community that offers a range of housing, amenities, and a continuum of care services for independent living to assisted living, which may include memory care, and skilled nursing, all on a single campus. Residents can transition between different levels of care as their needs change, with various contract options to cover these services over time. The Maryland Department of Aging is the agency charged with administering the continuing care laws. The existing nursing home at Vantage Point is a CMS 5-star rated facility which has 44 beds, all currently restricted for use by residents of the CCRC by regulation. As a result, CCRC located nursing homes are exempt from CON, which includes any reporting of their Medicaid participation rates. Next slide, please. Maryland Healthcare Commission need projection for Howard County is for 13 additional beds. And this project is to convert 13 of the 44 nursing home beds to public access, which will increase occupancy and revenue for RVP. Another project benefit is increased access for Howard County residents, particularly those who qualify for Medicaid. Project's total capital budget is $0, though it has a small incremental workforce cost increase as the nursing home census increases. Next slide, please. Staff evaluated the application to determine whether the proposed project is consistent with the applicable state health plan standards and whether the project is needed, viable, cost-effective, and will have an overall positive impact. After the thorough review, staff had a few concerns that we believe required the imposition of conditions. There are 3 conditions which all will require annual reports for a period of 3 years. I will go briefly through the recommended conditions, starting with health equity. The health equity criterion requires the Commission to consider how social determinants of health within the service area of the proposed project create disparities in the delivery of healthcare, and how a proposed project will address healthcare disparities in availability, accessibility, and quality of care among different populations within the service area. RVP did not sufficiently address this criterion. Next slide, please. The condition on health equity requires that Vantage Point provide the Commission evidence on fully meeting the health equity criterion for patients in the public use beds. It states that before first use, RVP shall establish community partnerships. Further, RVP shall document its strategies that will result in an increase in care access to older adults at risk for chronic diseases and with unmet social needs, due to a thorough patient screen at admission and appropriate referrals and alignment with community services upon discharge. We feel that it is important to follow up on the plans and success of the health equity endeavors of Vantage Point. Next slide, please. 2 Medicaid-related conditions are standard conditions, which are imposed for all new nursing home CONs regarding Medicaid participation. Medicaid reporting is required, of which, as stated, CCRCs are exempt. There was a correction made to the two conditions, which just emphasizes that the conditions apply only to the 13 public use beds. The first condition is that RVP shall document its progress in increasing the number of Medicaid patient days in the 13 public use beds. The second condition is that RVP shall maintain a proportion of Medicaid days at least equal that of all other nursing homes in the jurisdiction or region as required by the state health plan. Next slide, please. In summary, staff finds that with the conditions in place, the project complies with the applicable standards in the state health plan and the certificate of need review criteria. The project has been shown to be needed, viable, cost-effective, and will have a positive impact on the healthcare delivery system. And therefore, staff recommends that the commission approve the residents of Vantage Point's request to convert 13 beds of its 44-bed nursing home to public use with the conditions as discussed. Joining us virtually today from residences at Vantage Point are Alexis Hitchcock, Administrator, Joseph Mooney, Manager of Finance at Life Care Services, Kevin McDonald, Consultant for the project, and Howard Solins and Jack Eller, Attorneys. And that's it.
Okay, well, thank you, Eric. Do I have a motion to approve the certificate of need for residents at Vantage Point in Howard County?
Commissioner Cheatham, so moved.
Commissioner Danielle Stroughton, second.
Commissioner, okay. Stroughton, Duncan, okay. Do I have a second?
Second.
Commissioner Douglas? Is there any discussion?
Was identified for penalty release consideration under the offering.
Tracy, you need to go on mute. Sorry.
No discussion? So all in favor?
Aye.
Aye.
Is anyone
Aye.
opposed? The certificate of need for residents at Vantage Point in Howard County is hereby approved.
Chair Boyle, this is Howard Solins. I just want to thank the staff on behalf of residents at Vantage Point for its hard work and close coordination with us. We had a lot of questions that they were effectively answered that helped us put together a good application. I want to thank Kevin McDonald for being a consultant on the project. And we look forward to implementing as soon as possible. Thank you very much.
Thank you, Howard. Okay, Commissioner, okay, agenda item 5, which is finalize amendments to EHN regulation. Chapter 791, Senate Bill 748, and Chapter 790, House Bill 1022, Public Health State Designated Exchange Clinical Information enacted in 2021 requires MHCC to adopt supporting regulations. Draft final regulations require electronic health networks to provide electronic healthcare transaction information to the State Designated Health Information Exchange, CRISP, in support of certain clinical and public health purposes. So Anna Gribble, Assistant Chief, Health Information Technology, will present a draft final regulations. Anna, please proceed.
Great, thank you, Chair, and good afternoon, Commissioners. Next slide. So during today's presentation, I will provide an overview of the state law and legislative aims that led to amendments to COMAR 1025-07, provide background on the development of supporting regulations, review the public comments we received, and request the Commissioners consider approving amendments to COMAR 1025-07 as final regulations. Next slide. So the law that precipitates the proposed regulatory amendments I will review today, as the Chair mentioned, requires electronic health networks, or EHNs, also referred to as claims clearinghouses, to submit electronic healthcare transactions to the State Designated Health Information Exchange, CRISP. Electronic healthcare transactions are standardized communications between payers and providers, including claims information, that carry out financial and administrative tasks. Standardized electronic healthcare transactions improve accuracy and efficiency of the healthcare system. So information from electronic healthcare transactions will enhance data available through the All Payer Claims database and support the public health and clinical purposes listed on the slide and that are in the statute. The regulations support implementation of the law and also ensure that the technical process for reporting the transaction information to CRISP is informed with input from the MHCC certified EHNs. So as a reminder of prior actions, staff have previously presented proposed amendments a year ago at the October 2024 commission meeting, and the regulations were posted in the Maryland Register for a public comment period, and public comments were considered before reproposing the amendments approved by the commission, which occurred this past June. Next slide. So as mentioned, Chapter 791 passed in 2021. And this is the law that requires EHNs to provide transaction information to CRISP and CRISP to make the information available for certain purposes. And then earlier this year, the legislature passed Chapter 625, which clarifies that the transaction information may be used to support the state's participation in the AHEAD model, as well as any successor model. Next slide. So this slide overviews the timeline for amending COMAR 1025-07, which is the existing EHN regulatory framework. So from September 2021 to March 2022, staff convened 3 town hall meetings with representatives from EHNs and CRISP to inform an iterative implementation strategy. And then efforts to amend COMAR 1025-07 were put on hold to develop emergency regulations required by a 2023 law that prohibits the disclosure of legally protected health information by certain technology vendors, including EHNs. And then in May 2024, staff released draft amendments to COMAR 1025-07 for an informal comment period. In July 2024, staff convened a stakeholder working session to discuss those draft regulations. And then as noted earlier, in October a year ago, proposed regulations were approved by the commission and then published in the Maryland Register for a 30-day public comment period. And then in June of this year, the regulations were reproposed and approved by the commission and then published in the Maryland Register for an additional 30-day public comment period. Next slide. The staff considered comments from 6 organizations on the proposed and reproposed regulations. And comments included some reoccurring themes that centered on the potential uses of the healthcare transaction data, the reporting protocols, and compliance timeframes. There were some comments that did not result in a change to the amendments, and these generally included concerns with the law. Next slide. So in coordination with the AAGs, 2 changes were made in preparing the final amendments that were determined to be non-substantive. These include clarifying the specific transaction types EHNs must submit to CRISP, as well as clarifying the EHNs that are required to submit transactions to CRISP. Next slide. So while amendments to the regulations have been underway, CRISP has begun to engage EHNs to inform the development of the technical submission guidance, and this will serve as a resource for EHNs on how to submit transactions to CRISP. Next slide, please. So this concludes my presentation, and staff requests the commission approve amendments to COMAR 1025-07 as final. And if approved, we anticipate the regulations would be published in the Register in October with an effective date of November 10th.
Okay, well, thank you, Anna. Do I have a motion to adopt COMAR 1025-07 to finalize amendments to EHN regulation?
So moved.
Second.
Commissioner Jensen and seconded by Commissioner Gelroot. Is there any discussion? All in favor, say aye.
Aye.
Is anyone opposed? Okay, the action COMAR 1025-07 to finalize amendments to EHN regulation is hereby adopted.
Thank you.
Agenda item number 6, which is a mandated benefit study, HB 1147, scalp cooling systems, required coverage. Insurance Article 1501, Annotated Code of Maryland requires the commission to annually assess the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session or is requested by the General Assembly. The commission staff received a formal letter of request to study House Bill 1187 in 2025, health insurance scalp cooling systems required coverage from the House Health and Government Affairs Committee on April 23rd, 2025. Commission staff contracted with Lewis and Ellis, an actuarial consulting firm, to evaluate the cost of requiring carriers to cover scalp cooling systems for the preservation of hair in connection with chemotherapy treatment. Tracy Hughes, a principal consulting actuary from Lewis and Ellis, will present the findings of this study before asking the commission to approve the report. Tracy, you're there?
Yes.
Yes.
Hi, can you hear me?
Yes, thank you. Please proceed.
Great, thanks. Hello, everyone, commissioners. I think the slide deck should be up. I'm not seeing it currently.
Yeah, that's the, Levon, I think the wrong slide deck is up. This is agenda item 6. The Lewis and Ellis presentation, medical, social, and financial evaluation for scalp cooling systems.
I'm also happy to share my screen if that works better.
Maybe just give.
Yes,
like,
please,
30
please share yours.
Okay,
Thanks.
let's see. Is everyone able to see that?
Yes.
It's a little
Yes.
small.
Yeah.
If you can
Too small.
put it into presenter mode.
Let me see. Is that bigger?
Yeah.
Yes.
Okay, great. Let me see if I can even make it a little bigger. Okay. Great. So, Lewis and Ellis, as was just covered, was engaged by the commission to conduct a comprehensive evaluation for a potentially mandated health benefit of scalp cooling system treatment. The evaluation includes medical, social, and financial impacts. In doing this evaluation, we used several sources, including publicly available literature and statistics, a provider interview with a Maryland oncologist, a survey of Maryland health insurers, and also data from the Maryland All-Payer Claims Database. A bit of background: scalp cooling reduces blood flow to the hair follicles during chemotherapy treatment, which limits the spread of the chemotherapy agents to the hair follicles, which then helps to prevent chemotherapy-induced alopecia. Automated scalp cooling is the only FDA-approved type of scalp cooling. It is approved for solid tumor cancers, though not blood cancers. Manual scalp cooling is another available method. However, it's not FDA approved, but it is generally less costly since there's no automation of keeping the scalp cold. It involves dry ice and rotating the caps out once the cap loses temperature as it's applied to the patient. Most scalp cooling users are female. This is largely driven by breast cancer patients who make up about 80% of scalp cooling treatment users. Uptake among female breast cancer patients particularly is about 50%. Each chemotherapy treatment session is paired with a scalp cooling treatment cycle. So the scalp cooling occurs for a time period before the chemotherapy treatment and then after, averaging about 6 to 7 treatments per patient. Regarding medical effectiveness, we looked at various available studies. All of them really focused on breast cancer, since that is a large portion of the utilizers for this treatment. These were done anywhere between 2017 and 2024, showing a resulting effectiveness of 40 to 80% effectiveness in preserving hair loss, meaning that less than 50% of the hair was lost. Most commonly a reported side effect is a headache, and overall patient satisfaction is high at a satisfaction rate of almost 80%. There was a survey of oncologists done in 2021, finding that a little over 60% of oncologists support the treatment, though many still hesitated to discuss or recommend it to their patients, mainly citing financial concerns. As we'll get to later, it's generally not covered by insurance and can be a bit expensive out of pocket for self-pay patients. Although we could not get to the exact percentage of chemotherapy treatment locations that also offer the scalp cooling treatment, information that we did find suggested approximately 40 to 60% provide this therapy as an option. Responses from our carrier survey indicated that there's no challenges contracting oncologists at an adequate ratio for their covered population. The insurer survey also revealed that scalp cooling is generally classified as a cosmetic treatment and rather than medically necessary and is not covered. This was supported by what we found in the Maryland APCD, which was no claims data on the scalp cooling treatment CPT code. Medicare did begin covering scalp cooling in 2022 and has proposed to add it to the physician fee schedule in 2026. Currently, it's just a flat payment, a reimbursement. If approved for the 2026 physician fee schedule, it would be variable based on the number of treatment cycles. But as an example, the reimbursement would be almost $1,900 for around the average of 7 treatment cycles. Chemotherapy-induced alopecia is one of the most feared side effects of chemotherapy treatment, particularly for women. Studies we found ranging from 2014 to 2019 suggested that up to 10% may consider refusing treatment or choosing less effective treatment in order to avoid chemotherapy-induced alopecia. A total cost of treatment is typically between $1,000 to $3,000 on a patient self-pay basis, which typically it is a patient self-pay basis because there's generally no insurance coverage, though there are some nonprofit organizations that can step in and have stepped in to help with financial burden. For our financial impact estimate for the carriers, if this were to be mandated, we use this information collected through the various sources to come up with a range for each key assumption variable that would influence cost or utilization. Each assumption range is intended to capture the various uncertainties present and result in a final range of potential outcomes. Therefore, the final range captures many scenarios and sets of assumptions, not just the 3 that we point out as the low, mid, and high range assumptions. Detail regarding each assumption range and what we selected is further discussed in our full report. The resulting financial impact estimate was 0 to 0.05% of premium. And that translates to essentially 0 to 40 cents or 43 cents per member per month. We sort of see this as kind of a bell curve type shape where around the mid area is your highest probable or best estimate outcome, where a low and high estimates show sort of the outlier, less likely potential outcomes. And of course, outcomes will vary across insurers in particular, depending on their population characteristics. And that's all I have prepared for today, and I'm happy to take any questions if there are any.
Well, thank you, Tracy. Do we have a motion to approve the submission to the legislature, the mandated benefit study, HB 1147 scalp cooling systems required coverage? Okay, Commissioner Gelrude.
Second.
Second is Commissioner Douglas. Any discussion? Discussion, all in favor? Oh, that's it.
Thank you for this great report. Can you share why, the interview was with one oncologist and how that one was selected?
We use the help of commission staff to get connected with an appropriate and willing oncologist. This was an oncologist that perhaps the staff could elaborate a little further, but from what I believe, was sort of known for assisting patients and giving this treatment. She was very well educated on the treatment, how to administer it to she confirmed what we found in some studies, that about half of her female patients elected to go through with this treatment, and she helped them through that. I think that is how, part of how that particular provider was selected, but we did, like I said, use the help of the staff to get connected. So if there's anything you want to add to that, Jason or other staff, please feel free.
Sure. We had reached out to University of Maryland, MedChi, Hopkins, as well as I believe Commissioner Bhandari as well, to ask if they wanted to provide input or be included in the study. And this was from all of those reach outs, this was the one individual who, came back and showed interest and provided time to discuss the study with us.
Thank you. Any further discussion?
Now, just out of idle curiosity, I didn't reach out to MedStar or LifeBridge or.
I don't recall reaching out anywhere individually to LifeBridge or MedStar, but we had, spent time reaching out to the contacts that we had.
Yeah, cool.
Anything else? Okay, we have a motion and it's been seconded. Discussion, all in favor? Anyone opposed? Okay, so the submission of the mandated benefits study, HB 1147 scalp cooling systems, required coverage is hereby approved. So we are now going to go back to agenda item number 2. Bear with me with my. The next matter of the agenda is presentation by Dr. Jacobs. He'll update the strategic vision for the commission based in part on feedback from his one-on-one meetings with commissioners, mission staff, and other Maryland stakeholders. So Dr. Jacobs, please proceed.
Thank you. So you might remember, I'll just recap very briefly what we talked about last commission meeting. We went through a draft vision. We talked about, there was 3 policy buckets and 1 operations bucket. Those policy buckets were access to care, reducing disparities, and value. And then the operations bucket was supporting those. And so today is the next iteration of that. We're taking a little bit more of a deeper dive into those policy buckets and operations bucket. Are working together with staff, we've come up with some possible action items that the commission could pursue. I want to emphasize that these are draft at this time. As we delve more into the relative workload involved, we're going to have to figure out how to prioritize some of these areas with existing workload. And also during the previous discussion, I believe we had a comment related to identifying which one of these were regulatory and which were legislative. So the commissioners have a version of this that has identified where there's possibly needed regulation or legislation. The public facing version does not have that because this is not official legal advice, and I think doing my due diligence, I just needed to say that. So diving in here into the draft action items in the access category first, we have some of the primary care action items, and some of these action items we have to do because of various legislation that exists, or now the AHEAD agreement that has come out. And so this first item, establishing primary care targets and building accountability mechanisms, this is in the HEAD agreement with CMS. And so by October of 2026, we have to establish these targets. And so that's listed first. And as part of that, we have statutory authority to establish targets, but then also we're thinking through with state partners and other and amongst ourselves about how we can build accountability mechanisms. And so one way that we thought of is we could create a primary care champion designation for plans and providers that are investing sufficiently and meeting these targets, and think about how to utilize our quality arms to get that across. We also, as primary care practices are increasingly part of health systems, this is another recommendation as part of the primary care report last time, thinking about how we can look more into health systems to get information about how they're investing in their owned and affiliated primary care practices. And then also, this last recommendation that was in the report last time that you see reflected here is giving CMS more information to appropriately value services, both primary care services, other types of services, because we know how much we pay for services can influence the availability of those services in particular. So that's a primary care subcategory of access. Then we have some of the workforce categories. And so what I'll talk about in a bit is also there was a governor's directive related to our work with other state agencies on the HEAD model. And as part of that work plan, graduate medical education is on the agenda, in particular because this is an area where the Health Services Cost Review Commission has authority, and we can help with our convening to develop a strategy. There's also opportunities here potentially to expand access to telehealth, thinking about additional funding opportunities and otherwise. Also, what you'll hear after I'm done with these presentations is some work that we're related to utilization management and prior authorization and improving transparency and the evidence base there. And so that's listed here as well. And finally, in the coverage space, I think folks are aware that with the passage of HR 1, there are many individuals across Maryland who are on Medicaid that are subject to what are called community engagement provisions. Those are more colloquially called the work requirements. There are certain medical exemptions to those work requirements. And in working with CRISP, which has data from the electronic medical records, thinking about how we can make sure that people who qualify for those exemptions, meaning they don't have to satisfy the work requirements anymore, that we on the back end work to make that all happen. So that's kind of our supporting role potentially there. Second bucket, reducing disparities. We're thinking about this from a quality and safety perspective. How do we establish methodologies to ensure that we're rewarding providers that provide excellent care to underserved populations? Is there a way that we can establish designations for plans and providers that have achieved health equity accreditation, that have sufficiently changed their policies and procedures to demonstrate that they're trying to reduce disparities? And then as we discussed last time, the social determinants of health play significantly into the disparities across the state. There's that more than 20 life year difference in certain areas. And part of our role here, there are different social determinants of health screening tools that the different electronic medical record vendors incorporate and different health systems and practices use. We could think through how to develop interoperability standards amongst those tools. And so that's something that we could think additionally about. Also, some of the workforce that helps address unmet social needs and disparities oftentimes are community health workers. They're trusted sources in the community. And we're thinking through, particularly with some of the rural transformation dollars and additional ways that those services can be paid for. Is there a role that we could play to promote that type of care going forward? And then also we have, as you just heard, actually, with the Residences Advantage Point, there are health equity criteria specifically in the CON process. How can we think about that criteria going forward, and maybe adding some additional specificity? So we could take a look at those state health plan chapters. And then additionally, we're now looking at a social subcategory of these mandated studies, like the scalp cooling was an example of that mandated study. And ensure that those, like when there are certain disparity considerations, those are brought in. We also know that there's geographic disparities across the state. And so when we approach CON, are there ways that we can specifically promote access to care in areas that don't have as much access to care? And finally, with the new technologies that are really changing healthcare by the day, and in particular AI, how do we make sure that there are some potential downsides to these new technologies and incorporating biased data that then it gets entrenched in the system? And so in thinking with our state partners and folks that are using these technologies, how do we develop a better framework to protect folks from some of the downsides and promote the good sides? So that rounds out the reducing disparities category. Now, moving on to, yeah.
You want us to save comments, questions, or just throw something out
Yeah,
there?
yeah.
So I'm guessing you guys probably already know this, but if we go back up to under quality and safety, the quality rating systems. So NCQA has the designation. All I'm saying is we could steal shamelessly from people or use theirs.
I totally agree. Yeah. Yeah. So NCQA, and I think URAC also has one too. And so we could take a look at those for sure. Yeah. Yeah. Okay. And yeah, there's other comments. We're gonna leave some time for discussion afterwards too. If folks want to say that, but I'm.
This isn't an action item, so raise your hand.
Yeah. So this is more free form.
Right.
Okay. And then in the value bucket, and when I say value, the highest quality care in the most affordable way for consumers, and making sure that all the quality work that we do gets in front of consumers when they're making decisions about where they're going for care can be especially important. And so we're thinking through how to work with our state partners, including the Maryland Insurance Administration, on getting some of that quality information to folks. Yeah, go ahead.
Just on that, when the cost portion is presented, it'd be great if we could build a tool or shamelessly take somebody else's tool. It also factors in whatever coverage they've got. So what's their out of pocket?
In terms of like affordability for the.
Yeah, I mean, a lot of tools I've seen say, I mean, the cost is X for a procedure, but the out of pocket varies widely.
Yeah, that's true. Yeah.
So at that point, it's not particularly useful.
Yeah, the out of pocket is what people care about. Yeah. Okay. And then we're thinking also about how to improve our quality website and how to incorporate additional data from Medicaid and otherwise. And then also as part of the AHEAD strategy and using our convening authority again, how can we think through how to improve quality in long-term care facilities in particular? That would be alongside our partners in the Health Services Cost Review Commission and the Maryland Department of Health in particular. Yeah.
Just and then on the website, it's you're probably already doing this, but think about it. For the website in general and for particular sections, who's the audience? Because the presentation would vary pretty dramatically. And I think sometimes for the general public, some of the presentation is probably a little dense.
Got it. Okay. Right. Okay, and then the last subcategory of value is the competition category. And I know this is something that I heard a lot about from the commissioners. And we recently got authority over skilled nursing facility mergers, acquisitions, changes in ownership. With the market dynamics that are happening across the state, not only in skilled nursing facilities, this has been an area where we've been contemplating additional authorities. And that would need to be a discussion with the legislature. Next, also, even as we have the CON process now, how can we think about areas with healthcare monopolies? Because an area with a healthcare monopoly, you could have very likely increased cost. And by introducing competition into those areas, you could see a decrease in cost, more affordable premiums. And so how can we proactively think about our CON criteria to encourage that competition? And then finally, we've started this process already, updating our annual surveys to add questions to get more information if a facility has undergone a corporate transaction, merger, acquisition, change in ownership. That will help us get needed information to really monitor that going forward. Okay, so those are the 3 policy buckets, and then we have this operations bucket. And it's just as important, if not more important, to support all of those policy buckets as well. And so in discussing with the commissioners also, I think I also really heard a desire to make sure that folks understood what MHCC was doing, get a lot of our work out there better. And so we are working on a new MHCC website currently targeted for March. And that would, I'm pretty excited about that. So we'll come back to you once we have more to show there. When we come out with these reports, particularly where it aligns with our vision, making sure that we have a rollout strategy, we have press releases. And I think all the commissioners can be pretty helpful with this too. We can send out information when the reports have come out. And we can actually, something I've been meaning to do is send out some of the links to the previous reports from last commission meeting, the primary care report, prior authorization report. So if any of you want to share that information, you're more than welcome. We'd encourage it. And also thinking about our legislative strategy, thinking proactively about how we can work with the legislature, and then ensuring that our budgets and and we improve our technical expertise internally to rely first internally as opposed to contracting out for more. And that can also help. That goes hand in hand with the budget too, because that helps. And finally, we have this data category, which a lot of our work is based in this data across all of our centers. And how can we think in a future-oriented way about combining some of the information from CRISP with structured data and unstructured data from electronic medical records with the claims data. And that can allow for just we can ask new questions. We could be a lot more responsive to our state partners and stakeholders. And so that could really allow our analytic capabilities to just significantly improve. And then also creating some internal connections across the databases that exist, because data, I think, is one of our most important assets here at the Commission. And then actually what you all just approved in terms of the accuracy and completeness of some of our claims data, that's a priority too. So once that goes into effect, I think it will be particularly helpful. So I know that was a lot. I just breezed through, and I will say each of these action items, there's a lot of subtasks. There's thinking about work plans, and so the next step would, amongst staff, would be working on all of these collectively and plotting that all out so we can figure out what to prioritize, how to prioritize. But I would love to hear your thoughts with some of these action items going forward. And I will say this will be iterative too. Yeah.
Okay, I'll start.
Yeah, yeah.
I love it.
Okay, thank you.
I love it. Really. I would just put one comment in, and that is, as we look at using big data and different data sources, just keep an eye to how up to date are these data, because it's really hard for systems to make decisions based on data from 2022 when it's 2026, because you know how fluid this healthcare world is. So as much as you could push the more up to date, the better.
I love that. And with some of the transactions that we expect to come in to the APCD, it will be really important that some of this information, we don't wait for all the claims to be adjudicated, because the claims lag is a problem there. And so that is part of how we're thinking about it forward. Yeah. Thank you for that. Yeah.
Yeah, I too would add that I love this for many reasons, but particularly because this is Commissioner Douglas' 3-point vision that seems reimagined. And I'm particularly attracted to the external affairs. Even when I came and was on board, I was excited about the information that I learned. So excited, I was trying to run and tell everybody. And I feel like we shouldn't be the best kept secret. It's big work going on, and we work for the people. And they should know that and have some idea or concept of the work that we do. And so I like even what's bucketed here. We're starting with something that's simple, but yet so profound. We were giving away food in the local community. We weren't on the radio. Uh, it was word of mouth. So in the next day, we were able to give and feed 1,000 families, all because of things we put up in social media and our website. So I like where this is going. And we reimagine the entire commission and the approach to our work. Not so traditional. Yep.
Oh, yeah. Sorry, was there, oh, Commissioner Blake?
Thank you. Thank you again for your summary. Two things. I wanted to first kind of piggyback on what Commissioner Douglas had mentioned, and that's really being able to hone in on the audience that we want to share our reports and our work with. When we are disseminating all the great work that we're doing, we need to be very specific about how we're reaching different audiences and what our work means for those different audiences. The second is that I wanted to, when it comes to data, and I'm glad that we have a focus on data. I wanted to see if there was also a focus on collecting information about healthcare beyond facilities, particularly in non-traditional venues or homes that don't necessarily get the same type of attention that hospitals or clinics do.
Yeah, and so, and are you, just to be clear, are you referring to like assisted living facilities or like more personal care home type?
Yeah,
residences?
personal care. Yeah. Mhm.
Okay, yep. And was there any other types of like care environments that you were talking about?
Well, it could be more than that, but that's what I was initially thinking. Was
Okay, okay, thank you.
The small assisted living that are all over the place and hard to get your hands around, and how we do that will be interesting.
Mhm.
And I would add some are dangerous.
Yeah,
That's the other side of the coin there.
it's needed.
Mark there.
First of all, I'd like to underscore what Commissioners Blake, Gilbert, and Douglas said. I think I like the approach. I like the outline. I like the way it's being rolled out. I would just want to say though, again, we're going to have a lot of, different audiences for different parts of what we do. And I would like to see us be really thoughtful about what information is presented and how it's presented. And I think in my mind, it should vary pretty dramatically between the audiences. For instance, one of my the issues I've seen multiple times over the years is if you're looking at disparities in healthcare, you got to figure out who you're trying to serve. And if your best answer is a new app or a new website, perhaps that's not the most effective way to get that information out. Maybe it is, but we should just be thoughtful on those sorts of granular levels as we get to that. And I know that, Commissioner Blake already said that. So that's just me putting, an emphasis on her comment.
Thank you.
This is an exciting conversation that I know will continue over the next few months, and thank you for doing this. Are there any other great comments here?
So just one more, and I feel like I have to say it so I could sleep at night. But if we're harming people, we don't need to be here. So in the quality safety space, whether we're harming them financially or physically or socially, emotionally, that has to somehow be loud in here. Because in all of these ways, we could help people, but we could want to help them, but still hurt them. And that's not just in hospitals. So if there's a way to even strengthen that more, for me, that would be a great ad.
Yeah, absolutely. And I think as part of the, our quality work, we have a lot of those harms listed as part of the quality measures. I don't know all the intricate details, but I think it's a very valid point. And this safety movement in particular during COVID-19, in many ways, took a step backwards. And so refocusing on safety at this present time is especially important. So thank you.
I'm just gonna say one more thing.
Yep.
Safety in the workforce is huge. And in fact, the literature has married patient and workforce safety several years ago. And so I think, you know, we could be reflective of that. And speaking to, are we communicating with the right, in the way that different audiences can hear it, is part of safety, keeping them safe, because if they can't understand it, whoever that they is, you know, then we sort of just made it worse. That to me is harm. And I'll just say in one more area, if you don't know what your copay is and you choose that place to go and it guts you from being able to eat, we harmed you. Like, it's not safe. And so I would just implore thinking about it in the broadest view.
Yeah, thank you.
Amen.
Any other discussion? Again, it's going to be ongoing. Well, why don't we go to agenda item number 3, update of activities. And commissioners have received the written updates from our centers. And commissioners, do you have any updates on the, or questions on the written updates? So no questions right now. So Dr. Jacobs, please provide us with any updates that are not included in the monthly updates.
Okay, so you may have heard there's a lot going on with healthcare in this state right now. And one of those items is the AHEAD model and the changes to the AHEAD model. And on September 23rd, the governor issued a directive that created a regulatory working group. And our agency was named as part of that regulatory working group alongside the Maryland Department of Health, the Maryland Insurance Administration, the Health Services Cost Review Commission. And part of that directive was to develop a work plan to be submitted to the governor already 6 days ago on October 10th. So it happened so fast. It's between last commission meeting and this one. And so that work plan was submitted to the governor. And it called out some specific areas where MHCC has a role. And in particular, that's related to the primary care investment targets that we already talked about. We also have a role in convening for post-acute care and identifying a path forward, and also graduate medical education and the workforce as part of our convening authority as well. And so all of these would be done in conjunction with our state partners and is work that we would be getting done over the subsequent year. Additionally, the state received from CMS the draft terms and conditions for the AHEAD model. And there's one area in particular that I wanted to, it's a very large document, there's like more than 200 pages, but in particular, there's an area where the state must select 2 policy options, one from bucket 1 and one from bucket 2. And the state has to make their selection by January 1st, 2027. And so as earlier described, MHCC is on the regulatory working group, but this will be a discussion with stakeholders, will be a discussion with the legislature. But I wanted to, just for informational purposes, mention this to the commission, what the options are. So the first bucket includes 4 options. And it's number 1, implementing Medicaid site neutrality. Site neutrality typically means paying similarly for services, whether they're done in a hospital setting or in an outpatient practice setting. So that's the first option. The second option is improving access to new and or additional modes of care delivery via telehealth. Just as some color there, telehealth is something that MHCC has worked on in the past. This option in particular involves telehealth for postpartum care, and also telehealth in terms of fulfilling state interstate compacts. The third option here is advancing prescription drug price transparency, which is the state has worked on historically also. And the fourth option is prohibiting the use of non-compete clauses to increase provider mobility. In Maryland, we have non-compete clauses. We do not allow non-compete clauses below $350,000 currently. So those are the first bucket where the state has to choose one. I will say, it seems like there's more paths forward in that bucket. The second bucket is somewhat more challenging, and the second bucket includes this is promoting competition bucket. So number one, modifying scope of practice restrictions, including for physician assistants and nurse practitioners. What's involved in that is allowing independent practice for NPs and PAs. The state has allowed for independent practices of NPs and PAs. For PAs, there has to be a collaborative agreement with the physician. So the agreement then goes on to say, if you have already done that as a state, you need to select additional provider type and ease scope of practice rules for them as well. And so what exactly that means and what would be maybe open for discussion. The second one in particular has, I think, salience for this commission. It says repealing certificate of need requirements for all non-hospital settings. And we have 16 state health plan chapters. Most of those are in non-hospital settings. So this includes skilled nursing facilities, hospice, home health, and many others. And so this would obviously lead to significant challenges for the state in that this is how the state currently oversees mergers. So I know the idea is to promote competition, but if we got rid of CON, we actually wouldn't oversee mergers and there would be much more consolidations leading to fewer choice, potentially higher prices. This is also how we do surveys for all of these different facility types to assess for quality, and we make that data public. This is also how we ensure that all of these different facility types see Medicaid patients, see uncompensated care patients, which is going to take on even more importance going forward. And so there's a lot of problems here, I will say, but this is one of those that CMS is presenting to states as an option in this bucket. The third is expanding access to care by revising network adequacy provisions in compliance with federal requirements. I will say the details there include, I'll just say at a high level, allowing for narrower networks than existing regulations. So and I know this is kind of saying expand access to care by revising network adequacy provisions, but when you look at some of the details, some of that becomes apparent. I'm not going to go into a lot of the details there now. There could be some flexibility, however, with how CMS allows us to move forward with that provision. And so that is something that's one of the options. That's the third option. And the fourth is expanding contracting flexibilities by repealing any willing provider laws. Any willing provider law, what that means is that a state could say in the commercial sector or in Medicaid that the plans have to contract with any willing provider of certain provider types. In Maryland, we don't have a lot of that actually. It does exist for certain specific behavioral health providers. And so the state would have to choose one from that bucket as well. And the decision we have until again, January 1st, 2027 before making that decision. And this would be a collective discussion across agencies, the legislature, stakeholders. But that is what would be in front of the state. I can take a quick pause there and then we'd be happy to keep on continuing. Okay, all right. And then wanted to briefly mention, we released the primary care report, utilization management reports after last commission meeting. We accompanied that with a rollout plan, so a press release. And then We've also now, and this was an action item also listed, we've also set a placeholder for working on legislation related to mergers, acquisitions, changes in ownership. So, and that's for non-hospital settings specifically. So I think with that, those were some of the areas that I wanted to mention. A lot of the different groups, though, are providing more streamlined updates on their activities in this update of activities. And so they're doing a lot of really great work every day, which I've been very privileged to learn about. So I'll stop there. Any questions or thoughts?
Well, I'll obviously be curious to see how the options proceed.
Yeah.
And some of them are fraught with difficulty. We'll see what happens.
Yeah, I would also comment on that it's like a really big deal to choose these options, right? And I'm glad that there are different agencies who know a lot about it in the mix. And there are respectfully groups that know nothing or little about it in the mix. And so I hope we can at least provide a balanced education so the folks who don't know as much have a prayer to make educated decisions.
Yeah, no, that makes sense. Yeah. Other thoughts, comments? Okay.
Well, thank you, Dr. Jacobs. Want to introduce?
Oh, yes.
Yeah.
Okay, so we also, we have it. Apparently my voice is not cooperating. Okay, we have a new member of the Maryland Healthcare Commission, which I'm thrilled to announce. Let me get to my, okay. So, so Alex Bryden, she is coming to us. This is Alex. Can you stand up? She's coming in as our new chief of staff at the Maryland Healthcare Commission. Her first day was yesterday. And just some brief information about her. I'm thrilled that she's joined us. She's former chief of staff of the Office of Minority Health at CMS. And in that role, she also served as strategic policy advisor and expert on community health payment policy. She's been driven to improve and innovate America's healthcare system, provide higher quality, more affordable care for all populations, and particularly the underserved. And that was part of the Office of Minority Health's main mission. And so when she was at CMS, she created and led initiatives, including Coverage to Care, an effort to improve health insurance literacy for the newly insured, a technical assistance program focused on supporting providers and healthcare organizations seeking to improve care for underserved communities, and also drafted and implemented strategic frameworks to ensure all populations can receive the care they need at the right time at the right place. And so I'll just say that I had the privilege of working with Alex for 4 years while at CMS. I was in the Center for Medicare. She was in the Office of Minority Health. And I've just been really impressed by her thoughtfulness, energy, effectiveness, approachability, communication style. And so we were able to collectively make some changes to Medicare, the nation's largest payer, areas like paying for community health worker services, instituting ways that we're addressing disparities as part of our quality payment systems. And so I'm just thrilled that she decided to join the commission, and we're lucky to have her. So thank you.
The lemonade side of what's happening.
Yeah.
Okay, well, we are going back to the agenda and we're going down to agenda item number 7, which is presentation, Comar 102517, proposed amendments to prior authorization regulations. And 2024, the General Assembly passed Chapter 848, Senate Bill 791, Health Insurance Utilization Review Revisions. The law requires payers to implement an online prior authorization system, revises drug and adverse decision protocols, and establishes standardized benchmarks for automating reauthorization. The Commission is required to adopt regulations to support the law. Nikki Majewski of Chief of Health Information Technology will present the draft amendments to COMAR 1025-17 that will be released for informal public comment, which are intended to support transparency and promote evidence-based practices in utilization review. So Nikki, please proceed.
Thank you. Good afternoon, Commissioners. I'm happy to present these draft amendments to the existing pre-authorization regulatory framework. Next slide. As I go through the slides, I'm going to share some background on Maryland's law, federal policy, and a national industry pledge to improve the prior authorization process. And then I'll highlight objectives for amending the regulations and step through key draft amendments to Chapter 17, as well as next steps. Next slide. So to help frame the discussion, this slide touches on prior auth reform at the federal level that aims to increase transparency, reduce administrative burden, and ensure access to care. Federal rules obviously play a critical role in setting a national baseline. And so aligning with federal policy helps standardize prior authorization across payers and states. Next slide. In 2012, Maryland became one of the first states to enact legislation requiring payers and PBMs to establish online portals for prior authorization. Staff worked with stakeholders to develop supporting regulations, COMAR 1025-17, which required payers to implement 4 benchmarks, which are listed in the appendix of the slide deck included in your meeting materials. These benchmarks included requirements to provide online access to a listing of all medical and pharmaceuticals that require prior authorization and key criteria for making a determination. And then there were also requirements for an online system to receive and process prior authorization requests and enable a step therapy override process. So we reported to the General Assembly on payers and PBMs attainment of the benchmarks through 2016, and to date, all payers and PBMs have complied with the law. Next slide. New legislation enacted in 2024 requires payers to establish and maintain an online process for pharmaceuticals that meet specified parameters listed on this slide. This includes, technical requirements to link payer systems to e-prescribing and EHRs, as well as accept and approve, request, and make available at the point of prescribing real-time patient benefit information, like copays and other out-of-pocket costs. As you may recall from the presentation at last month's commission meeting, staff reported most payers have implemented the state mandated online process ahead of the July 2026 deadline. And PBMs confirmed they have the capability to provide the real-time patient-specific benefit information as required by the law. Next slide. There have been several policy developments at the federal and state levels as it relates to prior auth reform. And so these next 2 slides, I'll highlight key federal policy drivers that informed the draft amendments to Chapter 17. A CMS rule finalized in 2023 requires Medicare Advantage plans beginning in 2024 to make internal coverage criteria publicly available and evidence-based. And so prior auth decisions must also be reviewed by clinicians with appropriate expertise, and approvals must remain valid for the full course of treatment during transitions to new insurance plans for at least 90 days. Next slide. And so building on that foundation, CMS finalized a rule earlier this year that further strengthens protections for consumers enrolled in or seeking coverage from Medicare Advantage plans. And more information about other federal standards are included in the appendix as it relates to other rules that require federally regulated payers to implement technical and non-technical requirements, which includes connecting EHR systems via application programming interfaces. Next slide. And so lastly, just slide notes, an initiative implemented by AHIP and the federal government this past June in response to growing concerns about prior authorization in terms of delaying patient access to care. And more than 50 payers have voluntarily pledged to adopt more efficient, standardized, and transparent prior authorization practices. So this includes things like responding to prior authorization requests in real time and upholding existing prior authorizations. So Next slide. Okay, so now I'll overview our objectives for enhancing the existing regulatory framework and step through the draft amendments. Next slide. So listed here are the leading objectives, which, support implementation of the Maryland law, increase transparency and enable public access, ensure use of evidence-based coverage standards, and strengthen accountability and reporting. Next slide. So in terms of the draft amendments, we added healthcare provider to the chapter scope. And this is for waiver provisions related to that online process, which I'll mention a few slides from now in a new Regulation 7. We also added several new definitions listed on the slide here. This includes adverse decision carrier, concurrent authorization, clinical criteria requirement, healthcare provider, internal coverage criteria, online process, quantity limits, publicly accessible and widely used treatment guidelines. And then we are requiring payers to implement the online process consistent with the legislation enacted in 2024. Next slide. The draft amendments also require payers to make certain information available in a publicly accessible format by September 30th, 2026. This includes a comprehensive list by product of healthcare services that require prior authorization, concurrent authorization, step therapy, and quantity limits, contact information for related inquiries, links to internal coverage criteria, a list of internal coverage criteria for each healthcare service, along with the current clinical standards and evidence-based practices used in their development. Next slide. But this includes a list of the source citations, an explanation of the rationale supporting adoption of the criteria, identification of the clinical specialty organizations responsible, and a description of how the criteria align with current standards of care and evidence-based practice. Next slide. Requires peer-reviewed literature used to justify internal coverage criteria to meet certain conditions. Requires payers to include a text file online with the link to the publicly accessible information required under the regulations in Section A. It prohibits payers from issuing adverse determinations under certain circumstances and requires payers to annually review and update internal coverage criteria. And next slide. Requires payers to revise its policies as necessary to comply with these regulations. Also requires payers to make certain information available to the commission upon request, and to post on its website in a publicly accessible format certain information related to private review agents. Next slide. And lastly, requires payers to demonstrate compliance and submit to the commission a prior authorization utilization summary beginning in 2027 with certain metrics. Requires an annual coverage compliance review beginning in 2026, where payers must use an independent review organization recognized by the commission. It adds a new regulation for that waiver process for healthcare providers who are unable to access the online process, and then clarifies finding authority, including when payers may be subject to a penalty. So next slide. Next slide. So in terms of next step, we plan to release these draft amendments for an informal public comment period. We'll request that comments be submitted by the end of this month, but offer stakeholders up to 30 days if they need it. We'll then consider all feedback and anticipate presenting proposed amendments to Chapter 17 for the commission later this year. Final regulations are anticipated to be completed by Q2 2026.
Thank you, Nikki. Nikki, I have a question. What is the process? I'm thinking back when I ran a national patient organization for a group of rare diseases, and prior authorization would be a real problem. And at times, the quote experts they were going to were not true experts in that particular rare disease area. And some of the guidelines they were using were not appropriate. How would that be dealt with under these circumstances?
I believe Maryland law was enacted this past session or in the previous session, similar to the Medicare Advantage requirements that require the clinical specialty to be part of that review. So that somebody with the appropriate subject matter expertise can weigh in on those decisions.
Maybe just even to add, that's perfect. And even to add to that too, part of the requirements here, so transparent prior authorization criteria, number one. Number two, have to be based in evidence. And it's that based in evidence part that if it's these criteria are publicly accessible and everybody can see the evidence that they're citing, and they have to have high quality evidence that are actually supporting their points. Maybe they're actually using the appropriate guidelines, but maybe they're not. And all that information will become, we'd be able to see that and understand it. And then it would have to be based on the evidence at the end of the day, or they couldn't have that criteria.
Are we out ahead of most states on this?
I think a lot of states are making a lot of efforts to increase transparency. I think in terms of Maryland, this aligning with the Medicare Advantage policy is much more ahead of other states and some of the efforts they've got going.
But look, they're very exciting. Thank you. Comments? Okay, well, thanks again. And we're going to agenda number 8, presentation of the Maryland Maternal Health Report Card. The maternal and child health outcomes in the United States remain poor compared to other developed nations. The state of Maryland has long recognized this as a public health priority and continues to lead efforts to improve outcomes through transparent reporting and targeted initiatives. Courtney Carter and Teresa Brown will provide an overview of maternal and child health outcomes in the United States and Maryland, along with current maternal health-related public reporting efforts. The presentation will conclude with a demonstration of the new MDH Maternal Health Hospital Report Card and an update on ongoing maternal health initiatives across the state. So Courtney, Teresa, Stacy, please proceed.
Thank you for the introduction. So just to reiterate, are you sharing this one? We can go to the next slide. So again, we'll be talking, we're going to give a high-level overview of maternal and child health outcomes, looking globally, nationally, and here in Maryland. And then I'll share a few maternal health initiatives that we're working on here within MHCC, including some quality metrics that we report on. And after that, I'm going to turn it over to Teresa, and she's going to talk about some collaboration we're working on with MDH, and give a quick demo of the new Maryland Hospital Health Report Card. And then we will wrap it up with an overview of some other statewide initiatives, along with some outreach plans for the future. Next slide. Okay, so despite being one of the wealthiest countries in the world, if not the wealthiest, the US reports much worse maternal and child health outcomes compared to other industrialized countries. So a couple of examples, our maternal mortality rates are about 2 to 3 times higher than those seen in other high-income countries, and maternal mortality or infant mortality rates are nearly double. So there are a number of factors that contribute to these poor outcomes. By no means is this a comprehensive list, but I did pull out a couple of key variables that contribute. So that includes things like chronic health conditions, so diabetes, hypertension. Unequal access to healthcare also plays a big role. Health insurance, physical access to care, along with persistent racial and socioeconomic disparities. Next slide. All right, so this is a graphic that comes from the Commonwealth Fund, which I think is pretty compelling. So it shows a couple of things. First, It shows how the US maternal mortality rate compares to other high-income countries. So that non-US countries are shown in navy blue. And the United States is shown in that dark green bar. So it is the second to last bar on the right there. So you can see our rates are much higher than other countries like maybe Switzerland or Norway. But I think what's really more striking is the difference within the US itself. So those light green bars, they show maternal mortality for different racial groups in the US. So all of those racial groups are still more on the right side of this graphic. But when we look at white, Hispanic, and Asian women, the rates are still pretty high compared to those other countries. But what you have probably already noticed, that very high bar on the right, this represents the maternal mortality rate for Black women in the US, with a rate of nearly 50 deaths per 100,000 births. So that is over twice the national average. It's much higher than any group. So I think this shows a pretty clear visual of the disparities and some of those inequities that exist. Next slide. Okay, so nationally, Black non-Hispanic women are 2.6 times more likely to die from pregnancy-related causes than white non-Hispanic women. And here in Maryland, the gap is similar, a little lower, but Black non-Hispanic women experience maternal mortality at 2.3 times that of their white non-Hispanic counterparts. So we do always try to keep in mind and focus on, the numbers and the statistics and the graphs are great, but these really are families, mothers, communities that are being affected. So this is not really a new issue. Maternal and child health is one of Maryland's statewide priorities under SIHIS, or the Statewide Integrated Health Improvement Strategy, that launched back in 2019. So there is a lot of work being done in this space, which we'll discuss a little bit later on in the presentation. Next slide. So one way that we at MHCC can highlight some of these issues is through public reporting. So this is a screenshot of some of the information we have available on the Maryland Quality Reporting website. So it's probably a little bit small on this slide, but on the left, this is one way you can get to the hospital data, and we do pull out some maternal measures so that users can find it quickly and easily, and it is highlighted there, boxed in red. And that will take you to a page on the right. And so this is where you can see hospital-specific measures. We have a number of delivery and complication measures. And so you can also see the hospital score, the state score, and the national score, and you can compare facilities to one another. And it's really meant to make prospective parents be able to make informed decisions when it comes to selecting or choosing a delivery hospital. And I also just wanted to point out, there is a text box down on the bottom left side of the slide. We do have a short resource guide. We developed this several years ago. It's just kind of a short, sweet, printable PDF with some information for expecting parents. Things like how to choose a provider, some delivery volume information, and some other external resources that might be helpful when making these types of decisions. Next slide. So another way that we can try to look at this information is through the lens of reporting from large commercial health benefit plans using HEDIS measures. So we collect measures like timeliness of prenatal care and timeliness of postpartum care to really ensure that mothers are getting the care they need both before and after delivery. So this is a screenshot of how these health plan measures are presented on the quality site. So we can just go through this quickly. You'll notice that this particular health plan was a 2-star rating. And we can look at their scores. They're a little bit lower than the Maryland score. And we can see how Maryland compares to the nation, which is a little bit more favorable. And so this is just an example of one health plan. But overall, 7 out of the 11 plans that we report on performed at or above the national average rate. For both of these measures, timeliness of prenatal care and timeliness of postpartum care. So we are using this data that's available, and we're developing an issue brief. So that'll have more information about health plans that'll eventually we'll put on the website. It's not quite ready for prime time yet, so we don't have it today. We've sent it to a few of our partners just to review and get some feedback, but we will be happy to share that with commissioners once it's ready. And so with that, I'm going to turn it over to Teresa to talk about some of the exciting work we've been doing with MDH.
Can I ask a question before you go on? If, can we look at the slide with the bar graphs?
Sure. The slide 3.
Yeah, that's great. Okay, so I think on the next slide it is, we are comparing Black non-Hispanic women to white non-Hispanic women, right? And look, what we see in the US, Black non-Hispanic women is outrageously not good. So I don't want that to anyone to think I don't get that. But why wouldn't we compare the Black and white Hispanic and non-Hispanic women to the Asian women who are the best group in the United States, like they're faring the best. So why do we choose Black, white, non-Hispanic, but not compare both groups to the Asian women to, that's, we might get more out of it. Like, why are the Asian women doing the best? Let's compare everybody to the best versus stuck in Black, white is a question.
I agree. So white does tend to be the referent population.
I mean, that in and of itself is a structural inequity.
Correct. No, and I think it's also with Asian women, at least in Maryland, it's a smaller population along with Hispanic. So we do tend to, it's just how it happens. We tend to look at Black and white, but not to say those other racial groups are not important.
I think we'd learn more if we saw what was going right with the best group than being stuck where we are. I don't know that you could change that. I just have to say that out loud. And fascinatingly, when you look at people with diabetes, the Asian population fares the best as well. So better than white, non-white, non-Hispanic, whatever. And so that's who, in some places where I've worked, we compared to who's the best. Thanks.
No, thank you for that.
And hop forward a few slides to the maternal health scorecard. One more. Thank you. And thanks so much, Courtney. So as has been shared before in previous meetings, Maryland has passed the Maternal Health Act of 2024. So amongst other initiatives, one of the deliverables of that act is the creation of a maternal health scorecard for each of the Maryland birthing hospitals in collaboration with MHCC. So some of the required indicators are listed here on your slide, including volume, complications, patient input, as well as others. But the biggest difference in this scorecard, of course, is the Maryland focus. But the legislation did specify the stratification of this information by race, ethnicity, and age. So that information is not publicly available widely, at least for now. Next slide, please. So you'll see here a summary of our efforts to support the MDH effort. So we worked with our health planning colleagues to provide counts and definitions for beds, OB and otherwise, for each hospital, and we'll keep them updated as the subsequent updates go on. We also worked through various agency for healthcare research and quality, patient safety, and inpatient quality indicators. So some of those are listed there on your slide as well. But unique to Maryland, I do want to point out, we collect the patient level patient satisfaction data from HCAHPS surveys. So MHCC was able to provide that patient satisfaction data stratified by maternal service line, as well as those age, race, and ethnicity categories that I spoke to earlier. The last bullet at the bottom there, this dashboard did go live with some of the facility characteristics and some basic information in the summer. But we're happy to report that phase 2 was released on October 1st. So before we go through a full demo, I will touch on a few different initiatives just to reduce the logistics. But at the bottom there is the link for your future reference, and if you want to click on that. Next slide, please. So these are some of the ongoing initiatives across the state, specifically focusing on maternal health and patient satisfaction. MHCC is currently supporting a collaborative with HSCRC and MHA on patient satisfaction and those HCAHPS survey, focusing on stratified satisfaction data, as well as supporting quality improvement efforts as a result. Also included are our colleagues, the Mid-Atlantic Patient Safety Center, as well as MDH efforts like the partnership with MD Mom and the Babies Born Healthy initiative. The last bullet under those MDH initiatives is the digitization of prenatal and postpartum forms. So MDH is also working with that digitization as part of a 5-year HRSA grant in conjunction with the Maryland Maternal Health Act. So those are working in conjunction with the goal of increasing the use of these risk assessment tools in clinical spaces. There's currently pilots going on all around the state for that. And with that, I will go into the demo. So I will aim to replace the current screen share. I don't have to ask anyone if they can see my screen. All right, so here is your landing page for the maternal health report card. So you'll see our beautiful state of Maryland. All of these triangles represent the birthing hospitals across the state. At the top, you'll see a bit about the bill itself, as well as the different filters and options that prospective parents can choose from. So county or level of care, you can filter, of course, by what is desired there, as well as specific services that are provided. So say I would like to look at all of the NICUs in the state. You can select that radio button and you'll filter down to those organizations. So I will click through to Shady Grove as our example. All right. So this is Shady Grove Hospital. You'll land on facility details. So the menu on the left here, just to kind of orient you, is how we'll walk through. And you start with the highest level of information and go forward. So the bed counts, different services offered, and these are pulled from a range of different data sources, Leapfrog, different quality alliances, collaboratives, things like that. So there's a plethora of data explanation in the About Data tab, if anyone is interested in more detail there. Walking down that menu, delivery details on the left. So you can see here, these are live kind of buttons here, filters, if you will, and you can click through delivery hospitalizations based on those age and race and ethnicity and age groupings that I'd mentioned earlier, as well as additional options, menus, things like that to dive deeper into the data. The next section of the scorecard is the complication. So this is one of the new pages as of the October 1st release date, and it goes through a severe maternal morbidity, obstetric hemorrhage, and post-admission infection. You'll see that they're all stratified by all deliveries, vaginal and cesarean deliveries. And you can see it just at a quick glance that this hospital does not perform any different statistically from the state averages. And then if you scroll further down, there is that breakdown that we kind of discussed prior, the breakdown by race and ethnicity. And so you'll see here, these are all gray bars, which do indicate that they are not statistically different. But if you click on post-admission infection, you'll see here that this specific hospital actually performs better within the Hispanic population for all deliveries for post-admission infection. So just an opportunity to dive down and really select what you're looking for consumers, patients, as well as, of course, researchers and folks like that. It's down the menu again. You'll see patient satisfaction, a little jarring at first glance, but this is your kind of typical heat map showing the different indicators of highly rated or highly recommended by each hospital. And again, this is stratified just for the maternal service line, which that data is not publicly available. And I will point out this data is unadjusted. CMS does adjust their data in all of the performance plans. This is for quality improvement and informational purposes. So this is unadjusted. And you'll see here, you can scroll down and see how maybe a local hospital fared on these two indicators. And up here in the top right, you'll select the demographic that you're interested in and say, I am interested in age groupings. I am a young mom. I am an older mom. How does it fare when you break that down? So again, same view by hospital on the left, and each of the red and green to complement the higher and lower scores. If you do hover over any of these cells, you can see the N, the denominator. So there are smaller numbers included in this information, but it is suppressed under 10 responses. And same display here for race and ethnicity. You'll see significantly more white space. That does indicate that mostly Hispanic and non-Hispanic Black respondents had less than 10 responses within the 2.5-year time frame that this data is collected for. So we did want to include all of the information possible with those suppression guidelines. And I won't walk through the data dictionary. I think I'm the only person that clicks on those when I go to websites, but all of the information is here. And if you have any questions, I am happy to answer those now.
I'd love to see this data, an article in the popular press about how the chart on comparing the United States with other countries. And then this is what we're doing in Maryland. It's very comprehensive, very exciting, but again, the theme of getting it out there. If you could lead with this.
Thank you for the presentation. I love this data. It's clean, it's simple. What I prefer about it, if you were just talking, it would be difficult to understand, but this makes it actionable. So I'm like, what are we gonna do with the information? You know, it's kind of curiosity. Not for you to answer, but it allows you to come to some quick assumptions and some actionable items versus, you know, just having it written out. So I value and appreciate it. Looking forward to what the future holds. Thank you.
Thank you very much. Fabulous presentation.
Yeah, she's great.
There's a question.
Oh, question online.
Hi, this is Commissioner Blake. Thank you for your presentation. I really appreciate it. To kind of echo what Commissioner Douglas said, it's great to have this information, but it's really about how do we take this information and improve health outcomes. You had mentioned earlier in your presentation about maternal child health being a priority for Maryland. Is there a specific initiative that you know of or a specific program that is targeting improving health outcomes, particularly mortality rates for Black women?
So there is an entire maternal and child health bureau within MDH. And so I know they have a number of initiatives. I can't speak to them really in detail. But Teresa also listed a number of initiatives that are going on throughout the state. And there's a lot of collaboration. All of the agencies seem to be working together. And so there are definitely, actually, I didn't say this in one of my slides, but the rate in Maryland for non-Hispanic Black women has gone down a little bit. It was 2.6 and now it's 2.3. So I think we are slowly starting to see some of those improvements. And so hopefully that continues to be the trend, especially as this information becomes more public and widely available and people really start looking at it and they have that data to be able to make it actionable.
I'm so glad that you mentioned that. The reason why I asked is because I think that those are the things that we should also be highlighting. Is okay, these are the programs that we have initiated, we have started, and this is the results, right? And what do we continually need to do, and also what do we need to kind of add and support more to get the outcomes where we want them to be. But thank you.
And I'll just add, I believe I have an MDH colleague on the line as well to support. So I will make one comment while Jess decides if she wants to chime in or not. That the MD Mom initiative that I highlighted on the ongoing initiatives, it's a partnership between Hopkins and MDH. And they have a lot of kind of grassroots severe maternal morbidity. They're doing a lot of that collection by hand because there isn't available coding for some of the things that folks are interested in that are leading to it. So there is a lot of great work going on. That's one of the initiatives I'm familiar with, but maybe I'll see if Jess has anything to add.
Yeah, thank you. I'm Jess Hernandez. I'm the Data and Epidemiology Program Manager at the Maternal and Child Health Bureau. So the specific programming is a little bit out of my wheelhouse. I'm more of the data analyst, but I know I can speak to the fact that we have a women's health action plan, and one of the core goals of that action plan is to advance birth equity with a focus on Black maternal and infant health through the perinatal continuum. There's several different initiatives that feed into that, some of which have already been mentioned. They don't just serve non-Hispanic Black women. They are open, all of them are open to other people of all race and ethnicity backgrounds, but they all target disparities and are acknowledging of the disparities that exist, and try to provide care that is, recognizing of that. One of the examples I can give is we have a Centering Pregnancy program, which is group-based prenatal care. And so that increased in the number of sites from 4 in 2021 to 17 in 2024. It's predominantly folks who are on Medicaid. There are, I think there are some non-Medicaid folks as well, but a lot of great work that's been done in those group-based prenatal care programs. And then we also have the Maryland Perinatal Neonatal Quality Collaborative, which implements different bundles that they focus on to improve care with, and they work with hospitals. So that's something that's been going on as well. And we're continuing to do maternal mortality review and doing some integrated maternal health services care coordination work as well. So lots of things going on. I'm the data person. I worked on this report card, the hospital report card. So if there are any data specific questions or things that people want to reach out about, I'm happy to take questions and answer them. And I can also provide contacts to some of our programs, people who can give more information about programs that I don't know as much about, because I focus really a lot on the data analysis. But thank you so much for having me, and I'm happy to give my email and contact information so people can reach out.
Thank you, Jess.
Oh, thank you again. Appreciate it. Okay, we're going to agenda item number 9, overview of upcoming activities. And Doug, would you like to share some of the upcoming activities?
I would love to share some of them. So I'll just maybe start by saying, in the November and December meetings, a lot of our reports we have to do by the end of the year. And so you'll start to see that some of those reports, particularly in the next couple of meetings, will be coming through, because the intent of those is to get in for the legislative session. It starts in January. Okay, so some of the action items for the next agenda include data reporting by non-hospital healthcare facilities. That's our certificate of need, or Center for Healthcare Planning group. There's also a surgery center AAMC that's coming in with an ambulatory surgical CON. There's we're coming out with the data submission manual for our all payer claims database. And then some of the studies. So the Maryland, we have to do these mandated studies, I think, as folks know, when the legislature doesn't pass legislation related to certain coverage. And so we have a mandated study related to pharmacogenetic testing. There's a mandated study related to coverage for aesthetic services and restorative care for victims of domestic violence. There's a study related to coverage for biomarker testing. And then we are providing an update on the Health Information Exchange implementation on data sharing protections for legally protected healthcare information. And also we have a report on the most costly prescription outpatient drugs. And I think that covers it.
Okay. Okay, we'll go to agenda item number 10, motion to adjourn. Do I have a motion to adjourn the public commission meeting?
So moved.
Okay, Commissioner Gilroot.
Second.
Okay, Commissioner Douglas is seconded. And all in favor?
Aye.
Anyone opposed? The meeting is adjourned.
Thank you.
Funny, I hope you can-